There we go. So the base of the product is MedEtrax, and it's an Eobservations platform, originally designed for acute hospitals, but my background for many, many years has been in community health. And one of the things that we really wanted to do was to be able to give the same type of observation platform for patients out in the community, whether they be post-discharge observations or whether it's long-term conditions out in the community. So MedEtrax as a product is out there working, and it is the basis of it is the new scoring system, and it integrates with EPRs around the country that are already installed, but we can also give access to community EPRs and to GP services if that's required. And as you can see on the screen, we have a news chart which we automatically populate from the data that's put into the front end of the system. So if I move forward. Seems to have stalled again. Why is that? There we go. So one of the things that we mentioned is that we wanted to utilize the Eobservations platform out in the community. It's been well established that using Eobservations platform in the acute has a beneficial effect with patients, reduces mortality, reduces bed stays, and it's more efficient for staff on the ward as well. Given that, why couldn't we change the environment and develop the system to produce the same benefits for patients out in the community? There's abundant evidence out there. Some of the sources here from Accenture, which show that there is a reduction in hospital stays by 15 to 20%. If you're monitoring patients at home, there's fewer emergency visits, so patients can be sort of attended to in their own home, so we can intervene proactively based on the information that's being sent through to the support team, the clinical support team. We all recognize that keeping patients in their own home improves the outcomes for patients, so if we can keep them there rather than attending A&E and possibly being admitted through A&E, it's much better for the patients. Obviously, in doing that, it promotes efficiency, because if we're not having unplanned admissions, that releases beds for other procedures to take place. More carbon friendly, we're not having people driving around to outpatient clinics, to A&E, and for staff visiting patients unnecessarily. And it allows staff to look at the data that's coming in and proactively schedule their patients based on their clinical need, rather than just based on the care plan process that's in place at the moment. So in between visits, patients who may be showing deterioration will highlight through the dashboards or through the notification system, which means that community staff can attend and keep them in their own home. So patients at home, it's a logical extension of the Eobservations solution, and what we've tried to do is keep it as simple as possible. So the application, the patient end application, will sit on the patient's own device, smart device, either phone or tablet, and it connects with a Bluetooth observations system, which will allow you to record SpO2, pulse, blood pressure, skin temperature, respiration rate, and 3-lead ECG if necessary. We can also do questionnaires about how the patient is feeling. Have they experienced any dizziness, breathlessness? in the last 24 hours? Have they missed any medications, etc.? You don't have to have all of the observations, and you can tailor them to each patient, and you can also adjust the thresholds for notifications as well. So for instance, a patient with COPD whose normal SpO2 is between 88 and 90, we don't want the system notifying us every time a set of observations is done that the SpO2 is 89. That's normal for the patient. It's not normal for a normal person, but so we can tailor the notification systems based on the needs of each individual patient. We are device agnostic. However, we have chosen a particular device which allows a number of the things that I've talked about, the observations, to be done from one unit. And the benefit of that is that the application itself drives the unit. So once a patient goes into it, the system will take them through the observations that are necessary and drive the equipment and show the patient how to use that. MedEtrax can sit within the cloud, and we can offer it over N3 to patients and to hospitals as well. So the device that I've just talked about is the PM6100, a vital signs monitor, and it comes along with all of its equipment. It means that you only have one Bluetooth link, and we're not asking patients to disconnect Bluetooth devices and reconnect, which is difficult in itself. We also allow for certain observations to be put in manually, so that could be a blood sugar, it could be weight, core temperature using an ear probe. They can be entered manually as well if necessary. So patients at home, we can see some of the screens over on the right-hand side of the screen, and the home screen, which is the first one, allows us to see certain things. So we can see the patient history, which is graphical history. We can go into observations. We can put care pathways in there. We can have contacts, and underneath contacts, we can actually do video consultation as well. So if necessary, you could have a video conversation with the patient if you think that things are not correct. The next screen along further right is a little video. So when you go into the system, the screen will give you a video of how to put the finger peg on or put the blood pressure cuff on, etc. The lower left-hand screen shows you the results that have been put in, and we have a confirm button. And the next screen shows you the graphical history, which is sitting under the history button. The system is platform agnostic, so it can be Microsoft, Android, or iOS. Secure login. It links one-to-one to a patient record, which is held at the back end in the MedEtrax system. We can link to any number of systems out there, and we can also transfer data in and out. We have open APIs for both inbound and outbound messaging. We can share this data with anybody who we wish to give access to. So, as I mentioned before, that could be GPs, it could be community healthcare workers, it could be outpatient clinics, it could be the hospital themselves. We have visual trends through the news type scoring and graphing, which is done automatically. We can do this alerting and just notifications through to the patients that it's sepsis, that the patient may be going towards sepsis.
Charlotte, can you hear me? Charlotte?
Yeah.
Have I got the microphone now?
Yes.
I just wanted to say to John, that's a great presentation. Unfortunately, that's 10 minutes has just whizzed by, but I hope there'll be some Q&A that can release some of the further information you want to share with us. Just while we're getting Josh's slides ready, I thought I'd just make a couple of observations from what I heard you saying. So it's an established e-consultation platform in the acute setting that you're transferring to the community. It integrates with EPR and GP services. There's some data suggesting there's some good reductions in length of stay and avoiding hospital admissions, which I'm sure colleagues would be interested in hearing more about. It does notifications, and I like the fact that the vital sign thresholds can be customized for individual patients. Okay, so just give me the nod, Charlotte, when you're ready to hand over to Josh.
Yeah, Josh is loaded now.
Oh, thank you.
Yeah, the theme today is more around ultrasound imaging in primary care. So MDI, our company, was established over 30 years ago where we specialise in healthcare imaging and patient monitoring. So we're the distribution partner for GE Healthcare for ultrasound for the whole of Ireland. And they recently, a couple of years ago, given us the primary care market in the UK and Ireland to develop. So for that reason, well, primary care is the fastest growing area for GE for ultrasound globally. So say we're developing that market on behalf of GE because currently there is very little imaging done in primary care, and well, GP practices especially. I'm going to come on to the product by the slides shortly, but it was just more to give you a feel of what's going on at the minute within the market. But the main reasons why there is no imaging or very little imaging in primary care is the lack of a tariff model. So there's no incentivization for GPs within GP practice in primary care to do scanning, and also is a lack of training of either a GP or a healthcare assistant, so somebody to actually perform the ultrasound scanning. But apart from that, we've done a lot of work recently with exhibitions and events, and are seeing a growing interest in ultrasound in primary care, mainly due to the obvious demand on with ultrasound referrals into the secondary care system. So as part of the NHS's long-term plan, they're wanting to move more services into primary care, be with that diagnostic point of care imaging. So the benefits of ultrasound in primary care is earlier identification of key symptoms, which are identified as ones that can be done more in primary care, which will include cardiac, echo scanning, identification of DVTs, renal, gallstones, for example, ascites, hydrophenosis. So these are a lot of symptoms that, especially in care homes, can be picked up using ultrasound. So the other main reason is to not take people into secondary care, so reducing the need for travel, the upheaval it is for patients to get into acute hospitals just for simple scans, reducing that stress, obviously, for the patient and the ultimate cost, really. And also it's improving the clinical pathways, so by using ultrasound at primary care and being able to diagnose or identify a lot earlier, you can then allow the patient to go on a more defined clinical pathway. So if they present themselves in primary care, using ultrasound as an additional tool for examination, you can identify, rule in, rule out. So, for example, does the patient have gallstones, yes or no? Well, if he does, then we can refer straight to a urologist, for example. So it does really define that pathway for the patient. So, say with the correct training, GPs, etc., within primary care can make a lot more informed decision making. Ultrasound obviously has no radiation exposure, so it's very safe compared to the likes of X-ray, and we can also integrate the imaging into electronic patient records or a PACS system. But obviously for the care closer to home theme that we've been talking about, like we did at Preston earlier in the week, medical care for older people at home or in a care home is currently organised through general practice, and there's varying levels of expertise in the care of older adults, and the main primary care team is the only accessible during normal office hours currently. So care home staff are therefore the main deliverers of complex care with variable support from other providers. So this poses a risk and a challenge for care homes where there may be multiple practices providing care to a single home, and so there's different access throughout the 24-hour day on different days of the week. So if we can bring that care into a care home by using diagnostic testings, for instance ultrasound, then obviously we can start creating a better experience and the pathways for the acutely unwell. So this is where point of care diagnostics and the technology can help a rapidly responding clinical team, for example, paramedics who can then go into a care home or a person's home and deliver that diagnostics, and then within a lot better time frame than currently by having to refer into secondary care or or acute hospital setting. So now the type of devices, so the ones that I'm promoting here, which we do with GE within primary care, is the handheld ultrasound, the V-scan. So this is already used for the likes of echo scans, etc. So the main benefit is it's handheld, it's it's easily portable. Just trying to get the slides to work here. So the main benefit of the V-scan is it's a dual probe, so you can cover 80% of the body with the V-scan itself. For some reason, the slides aren't kicking in. Oh, there we go. So it fits in your pockets. So it can be, a lot of paramedic teams currently use these, ambulance teams. So it is a widely used device currently, but not as much in the primary care setting. So this is what we're trying to improve and get more use with. So as I say, it's a dual probe. It covers 80% of the body. It can connect with PACS networks, so we can instantly share an image that's taken, for example, at a trauma instance or at a care home, and we can share that image instantaneously to a consultant if needs be, or connect it straight into a patient record for future referral. The good thing with the GE system now as well, it's all app driven. So we've got a lot of new apps coming on board, where there's a bladder volume app, there's a ScanCoach, which allows further teaching of how to use the ultrasound. There's lung modes, lung protocols. Viva, so that's currently getting used. Now that is an ejection fraction application, so that if you get a good 4-chamber view of the heart, this will actually, using artificial intelligence, measure the ejection fraction. And so this is used now for early signs of heart failure. So we've got consultants down in London who are trying to train GPs to then spot ejection fraction as one early sign of heart failure, and then that image can be instantly shared to a consultant to then advise, right, get them on medication early, so they're not having to wait 3 or 4 weeks for them then to see that patient in acute care. So this is all getting heavily invested and backed. We've got new DVT applications coming out as well. So it's a really great diagnostic tool or identification tool for the key things is early identification of these key symptoms that can be dealt with in primary care. So these are just examples of the bladder volume app. So again, this can easily pick up, especially within care homes with hydrophenosis ascites, gallbladder stones, simple things which can, with a trained person, can easily pick up using the V-scan ultrasound. It's just listing a few. So you can also create your own protocols to access images and configure your imaging to what you're trying to ascertain from a patient. So, and then store pathology within the V-scan as well. So that's an example of the Viva, which measures the left ventricle function and gives that ejection fraction reading. So anything less than around about 40% usually determines quite a low ejection fraction, or that can be, that is something open to discussion, but obviously with a good view of the heart, you can easily identify if there is issues there. And this is a ScanCoach, so we're also heavily involved with introducing ultrasound into medical schools to teach the future junior doctors. So this is going down extremely well. I've got a lot of medical schools where they're now using the V-scan to train their students now, so they've got the clinical skill of ultrasound. It also helps with the teaching of the anatomy. So we're taking it a step right back to try and get more GPs trained in the clinical skill. Because obviously abroad, in the likes of Germany, for instance, every GP is trained in ultrasound. So, but the difference is they're rewarded for scanning in primary care, which isn't the case currently in the UK, although it is a lot of consultants saying it's just a matter of diverting the funding and the tariff model into primary care for it to be done, a lot more widespread. So, say the ScanCoach is a unique tool which helps guide early adopters of ultrasound, so we can help with all the training that needs to be given. Then the device can also screen mirror. So this is great again with the medical schools, or even if it's with use of the GP practice, because the V-scan isn't only a small device, but then you can mirror the image onto a large screen within a GP practice, for example, or in a medical school. So then you can see the images, and show it on a bigger screen. So linking with the patient record systems. So we have various different ways. So we can securely link up to a PACS system. We're also speaking with the likes of EMIS, so we can...
Josh, can you hear me?
Yes, yeah.
Just one more minute, if you don't mind.
Yeah, no, that's fine, yep. So yeah, as I say, the other unique thing with the V-scan is we can integrate with electronic patient record systems. As I say, we're already speaking with EMIS, so we can automatically upload the image into the patient's record. And we can also archive into a cloud PACS system, so images can then be shared and stored within a cloud environment and into an external PACS system. So then it follows the patient journey then. So, a record of ultrasound images can be kept with the patients, which is obviously going to be key for any widespread use within primary care setting. So, yeah, well, I'll leave it there. Hopefully that's covered enough information on what we're trying to do and the V-scan product itself, and obviously to have any further questions later on.
Okay, great. So if I can just make a couple of general observations. So you started off by sharing with us that ultrasound imaging in primary care is quite limited due to the fact there's a lack of a tariff model. So that might be an interesting question for after. It can be used in cardiac, renal, gallstones, carotids. There's a belief that it might reduce referrals to secondary care. That might also be interesting for debate after. The AI to help with ejection fraction measurements in heart failure, if the cardiologist supported that could be pretty significant as well. So thanks for that, Josh. There will be questions later on from myself and the delegates. Sam, if you're ready.
Yes, yeah, I'm ready to go.
Great.
Okay, so hi everybody. My name's Sam Scott. I represent a company called Rinicare. The presentation appears to have disappeared from the screen. Not sure where that's gone. Do you want me to use mine, Charlotte? Are you okay with what's coming up on yours? No. Okay, that's fine. We'll use what's on the screen there. That's not a problem. It's fairly easy to follow. So yeah, Rinicare has been going for a number of years, 6 or 7 years now. Initially, a lot of research and development projects that over the course of a few years we've turned into products that are ready for sort of commercialization and use in the wider NHS, which is why I'm here speaking today. We have a couple of things that hopefully will be attractive to people. So a little bit about our history. We work very closely with a number of NHS trusts, universities, so we're quite grounded in what clinicians are looking for. We don't shoot our park up and try and design something that we think might work and is not actually grounded in reality. So we have a board full of medical professionals. We have quite a few pilots up and running, and our history is, like I say, in the R&D space. So we're quite well versed in what people are looking for. In terms of our aims as a business, we believe that the digitisation of healthcare is the way forward. Obviously, the NHS needs to do more and more with seemingly increasingly finite budgets. So we introduce technology to help people avoid hospital as a first port of call, and if they are in hospital, how can we treat them better and get them home quicker? So we have two systems that do that. The first one is ready right now, and that's called Prime, and that's what I'm going to spend most of the time talking about. But there's a secondary system called Safe, which is quite exciting. Although not ready at the moment, it's worth a couple of minutes of your time. So the first one is Prime, and it's essentially a remote vital sign monitoring solution. So it consists of a suite of Bluetooth sensors that connect to a central hub, and that hub then connects to the user's device, so a tablet or a phone, to visualize data. It comes in sort of a case-style package, in a briefcase style, but it's a lot more than just being another bit of kit. It enables remote assessment of patients. So these kits can be deployed in care homes. They can go out with district nurses. GPs are currently using them for their home visits. It's a way of basically providing care in a non-clinical setting. So in the box, in the sensors, there are a thermometer, SpO2, blood pressure cuff, and 12-lead ECG. I've got it down to, when I do a session on an exhibition stand, maybe some of you have seen me, I don't know, I can do a session in about 90 seconds to 2 minutes. So that's going to a patient, inputting some basic details, taking a session, and then obviously visualizing all that data. And once it's in a PDF or in some sort of digital format, that can then obviously be distributed worldwide or wherever that needs to be. On the back end, we have linked in with both EMIS and System 1. So the GP practices are finding there's a bit of a time saver in terms of collating information from the field, even if it's just a basic benefit, such as at the end of all the home visits, it's great to just know everything's logged. You can close the kit, and that's the end of the day, rather than knowing you've got sort of 40 minutes worth of notes to write up when you get back and you've actually only done half the job. So little benefits like that, right the way through to improving patient outcomes, reducing hospital admissions. These are all things that we're finding out about the system at the moment. It's relatively new. It's only been up and running for 6 months or so, so we're still finding out its area of the market that it's going to have the most benefit in. But these are some of the early things that we found out about it in terms of obviously portable, accurate, versatile. It's starting to make really big noises. It's not a static product as well. It's something we're developing all the time. So since it's come online, we've added in the patient record integration, as I've talked about, but also we can dynamically calculate a news score. So on site, nobody has to get the calculator or their fingers out. They can manually they can automatically get a news score by the second. And then we're moving on to things like integrated spirometers, glucometers. So essentially where we want to get to is a complete remote kit that is customizable. People can chop and change the sensors, and it really works for different areas of primary and community care. So obviously glucometer is going to be massive for the diabetes leads that go out into the community and maybe deal with housebound patients and stuff. So that's Prime in a nutshell. I hope you think it's useful. We certainly do, and we're certainly getting good feedback. So then the other system I wanted to take a couple of minutes to talk about is Safe. So Safe is a little different. Prime is it is a trendsetter, but there's quite a few other people that are in that space. So obviously that's more competitive, and there's other people that do things slightly better than us, and we do things slightly better than some other people. Safe is breaking entirely new ground. So Safe is a falls prevention system. It uses thermal imaging in a camera that's positioned above the bed, and then we feed that data. A frame comes through every second. We feed that data through an algorithm that can prevent patients from falling. How it does that is it alerts nearby clinicians using portable devices, using a central nursing station. It alerts them if a patient has moved, if they're a high-risk patient, have they swung their legs out of bed, have they shifted their weight. All of those sorts of alerts, they're fully customizable, so you can tweak the sensitivity to how much control you want to have. And like I said, it then sends out the alerts for people to take action. So it's currently in for trial with Royal Lancaster Infirmary, and it's going really, really well. The nursing staff love it. It's an extra pair of eyes for them. It's not going to replace anything in terms of reducing staff numbers, or it's not going to change the makeup of a ward. It's just an extra pair of eyes. It's an extra alarm that allows them to quickly and reliably understand what their patients are up to. So there's obviously a number of different use cases here in terms of post-operative, dementia wards, geriatric wards, all these kinds of things that are potentials for SAFE. What I want to talk about a little bit now for a couple of minutes is obviously in the community. It's great to stop patients, inpatients falling. That's obviously a massive goal of ours, but we see the real benefit is getting this out into the community. So this would be into care homes, even into private residences, and being able to prevent falls where they happen most. So obviously a lot of care homes have single occupancy. Perhaps they do struggle with staffing, all these kinds of issues. Perhaps the building has been converted and is actually, very long. It has long corridors, lots of doors, all these kinds of things that block line of sight. This is a system that could be plugged in and actually gives peace of mind to the patient, the resident, their family, and the staff in the care home to say, look, here's a central system that we can monitor what people are up to, and if room for, if they'd like to go to the toilet at 2 a.m. And they're motioning to do that, we can know within the second that they're on the move, and we can get to them. I know that my grandmother took anything from a minute and a half to actually get out of bed. So SAFE will let you know within the second that patient's on the move, and then obviously it's up to the staff to take over. So it's much more of a passive system, but then obviously we've overlaid some predictive AI into there. We have historical logs, so if you suspect somebody's had a fall in the night, maybe they've got a new bump or something, but they're adamant they haven't, you can check a historical log to see their body positions. It's all discreet, and it's not Big Brother watching you. There's not cameras on there's not big visual cameras on the wall for you to monitor people 24/7. You get pictorial representations of what's going on the bed, so it protects patients' dignity, their privacy, but it is, like I say, to the second and very accurate. So with both Prime and SAFE, we really want to push care away from the hospitals and into the community. The NHS are responding relatively well to it. It obviously provides better patient outcomes, and it's more patient-centric. It's giving them more care and better care when they need it, but also it's helping the NHS from a business perspective of this is a cost reducer as well. So say, for instance, ballpark figures, it would be roughly around £2,000 to £2,500 to get a bed equipped with SAFE and to get it all hardwired in. But obviously, if you can prevent a hip fracture, you're looking at £40,000 to £50,000 worth of surgery and rehab. So the cost benefit does start to match up quite easily when you start to roll this out in real terms. So that's where we're up to at the moment. Prime is a little bit ahead of SAFE, but they're both quite exciting. And yeah, I'm open to questions if anybody has any, and that pretty much wraps it up. I don't want to drone on, so that's everything. Okay, so thank you, Sam. Just a couple of observations from me on your talk. So similar product to John's. Again, you emphasise digitalising the NHS, which you all know is a big challenge. Two products. The one you focused on most was Prime, so remote monitoring of vital signs, and SAFE sounds interesting for the falls monitoring using imaging. It'd be interesting to see if any delegates would like to offer their hospital or setting for some trials or evaluations as well. So remote monitoring in non-clinical settings, 2 minutes to set up. That sounds really cool. Also linked to EMIS and System 1, and likewise you made the similar claim to John about reducing hospital admissions. So so if I could just ask people to start thinking about the questions they've either got in their mind or they'd like to ask, just a couple of quick observations from me. So on Tuesday, we had over 100 delegates at the ECO event in Preston, focused on point of care testing and e-consultations. And one of the things I think that I took away was, well, two things. So why is point of care testing so important? I think it's a little bit obvious to us all. There's a huge demand in terms of there's less staff than there used to be, and there's more patients than there used to be. And everyone keeps talking about patient activation and patient engagement. This is a great opportunity to do that. So I think you'd actually realise greater patient control, confidence, and compliance. But that's going to require clinicians trusting patients to be more involved, because it's not just about the technology, it's the cultural piece around the trust. So do we have any questions? I can't see anything in the chats. Can people raise their hands or write a question?
if they have one. No questions. Do any of the panelists have any questions for the other panelists? Otherwise, I'll ask some questions.
Yeah, just a question from Sam at Rinicare to John. Just a quick one regarding the tolerances the customizable tolerances. We've sort of looked into that ourselves. Is there any sort of medico-legal issues around that you've experienced? Obviously, I know more than likely it'll be a clinician that sets those tolerances. But have you encountered any sort of difficulties or any sort of concerns on the behalf of the clinicians with setting those tolerances?
No, because when the patient is referred into the patient's home service, it's the clinicians who set the tolerances, and it's fairly well established within the new scoring system for things like target SpO2s. So within News 2, you have 3 bands of SpO2 targets,
Sure.
and that's based on the patient's condition. So although there is the ability to vary the thresholds at which notifications come out, it is controlled by the clinicians. It's not controlled by the patient.
Right. Okay. Now I'm with you. So the responsibility still sits with the clinician. It's just a bit of a sanity check for themselves.
Yeah, absolutely. Absolutely.
Okay. Thank you.
Okay, so just I can't see any questions yet. So I have a couple, and there's a subtle difference between the two of them. So can I just ask everyone on the call, but especially the panelists, what are the challenges to point-of-care market penetration? So if we know that less than 10% of primary care is using point-of-care testing, what are the challenges, not the barriers? So I guess I heard, was it John saying, no, sorry, Josh, saying there's a lack of tariff model. So that for me would be a challenge industry would have to overcome.
Yeah, that's right. That's what we're finding. There is money in the system. Obviously, it's the acute hospitals get a tariff for scanning in obviously the secondary care, so the money is there. It just needs diverting into primary care in order to make it attractive for it to be performed at primary care, but obviously that goes with having a trained person to use the ultrasound as well. So it goes hand in hand, really. But yeah, that is one of the key things, or both of the key issues currently within primary care for ultrasound.
Okay. How do clinicians react or respond to point of care testing? Are they fans of it? Are they cautious? Are they suspicious of it?
No, they all see the benefit in it. It is more, I think, it's identifying the key symptoms and allowing primary care to take some, of these earlier identifications for, like heart failure, more echo in primary care. There is external providers who can do it, and like we mentioned earlier in the week, we seem to be seeing a growing interest from GP federations now with these super partnerships forming. So it's an additional services they're keen to take on, and then hopefully benefit from a tariff model to be able to commercially provide ultrasound, so it's commercially viable, but also then enables the patient to get the earlier identification and better experience than they currently get with long referral times.
Yeah, so it's helping them see the future through the big picture.
Yes, yeah.
So
from our side, I think one of the challenges is with the clinical staff, the clinical team supporting patients out in the community. It's the perception of loss of control, allowing patients to put their own data in, and the impact of that, and I suppose the element of risk that comes along with it. But once you actually have patients using it, the quality of the data is actually very, very good.
So,
Steve,
go on. Yes.
we have a question just coming through for Josh, just just to double check whether or not the reference in presentation 2 was for News 2 or News.
For new to, or for what was the question again, sorry?
Sorry, the reference that you made, was it to News or News 2?
Is that from John Hopkins?
Yeah,
It says presentation 2, but maybe it wasn't. Maybe it was yours, John.
Yeah, in terms of the algorithm we use and the acute side, it's based on News 2.
Okay. Just also, we've got a question or an offer actually from Des Goten. If any of the presenters would welcome a conversation where you're trialing any of their devices. So what we can do is, he's on the Wirral. We can connect the three of you up to Des after this call.
Excellent.
Great. And we have Mondeepa asking, can you speak of the cultural issues that you mentioned?
Yeah. So before I open that up to the others, I think there's two things. I think the patients are largely passive, so we know we do stuff to them. And this perception of the loss of control that clinicians are worried about is in conflict with the agenda closer to home and patient activation ambitions that we all hold. And if you think about the trust factor, I'll give you two examples. We've trusted diabetics to manage their insulin for a very, very long time now. We've not transferred that same trust to patients on warfarin to monitor INR, and you can make all sorts of clinical arguments for it. The technology and the new drugs exist for there to be parity for that. A second example is it's not just about technology, it is about trust. We've got a colleague who shares her story, Jen, and she had cancer, she survived it. She was asked to go and weigh herself every week at the local hospital, and that took her an hour to get there and an hour to get back, and sometimes she had to wait. She could have easily just stood on her scales at home and rang or emailed her weight into the system. So when we talk about technology, don't forget it's also about trust. So does anyone else want to make any comments? Because that's the cultural piece is a really big piece.
This is John from MedEtrax. I think the other thing is the way in which the data is used as it's being sent back in. There is potentially a lot of data, and how that's sifted and monitored using notification systems is very important, and that is a change in the way in which care in the community is viewed.
Okay. Anybody else? So I can't see any other questions, Charlotte. If it's all right with you, I have two big questions that came out of the roundtable event, which I wouldn't mind sharing with the people on the call, and we'll email these to you as well. So we know we're quite task-orientated and quite reactive in the NHS, but if we were going to be more strategic, we would ask probably two key questions to help the adoption of point-of-care testing. So not early diagnosis, but early detection. And what diseases are a priority for greater remote monitoring? And I think the second question, if we got hold of the data, we'd know where to focus first. So which settings would benefit the whole of the NHS system the most if you had more point-of-care testing available? And I don't know the answer to that. It might be primary care clinics, it might be urgent care centres, it might be outpatient rooms, it might be care homes, it might be ambulances, of course it might be patients' homes, and it might even be pharmacies. I think they're two big questions we definitely want to try and encourage the ICS to get the answers to.